Hey everyone, and welcome to another NLP Insider live show. And thank you so much for joining us today. We are here live every other week for 15 minutes to talk about everything NLP with industry leaders. My name is David Talby. I'm the CTO at John Snow Labs. And today I'm excited to chat with Paulo Pinho, who is the Vice President and Medical Director of Innovation at Diameter Health. Paulo has global experience in healthcare delivery in various care settings and is innovating in health tech, personalized medicine and automation, and other things he will talk about today. In today's show, he'll tell us more about using NLP to drive medication instruction parsing. Welcome, Paulo.
Thank you, David. Good to be here.
Good to have you here.
Thank you.
So let's jump right in. So Paulo, you've been a practicing physician and clinician. You started your career as a physician, and today you're the VP and Medical Director at Diameter Health, which helps organizations basically realize value from clinical data. Can you tell us a bit more about your background and how you got to doing this today?
Yeah, so I have so I'm a board certified internist and pediatrician, double board certified. I actually ran my own medical practice for about over 10 years. In total, I was in practice for 15 years. And basically, what I began to notice at that time while I was practicing is that documentation at a provider level was increasingly challenged. Electronic health records had just come out. It was important for me to use technology to best serve my patients and to best capture their entire care journey. But I started realizing that there was tons of fragmentation. Although I may have had sort of seamless integration within my office and all of the data kind of flowed into one system, I started realizing that that wasn't the case as I started to interact with other specialists, with hospital systems, with labs, et cetera. I was one of the early adopters of electronic health record technology. When I was in private practice, I was the second meaningful user, which was actually an incentive program that the government set forth for physicians to use electronic health records. I was the second meaningful user in New Jersey. I was heavily involved with health information technology. I was a fellow under the Obama administration's Office of the National Chair, early on in my practice. And I really began to sort of become, enamored with the idea of using clinical data that came from multiple different sources and multiple different formats to really drive clinical outcomes. After leaving full-time clinical practice, I did work in the data field, less so around data interoperability, but had the opportunity to meet with Diameter Health team members. And quite honestly, I've reached career nirvana because I'm solving many of the issues that I experienced as a provider and that led to many of the challenges in care delivery that patients experience, having to tell their own story, having to sort of piece together all the different specialty visits and hospital visits. And I've gotten really focused on standards and standards documentation of how of care experiences and how to really bring different care experience in different formats into one common record that really tells the whole story about a patient so that they don't have to tell it for themselves.
Mm-hmm. So what are some of the big challenges that organizations in healthcare face? What do you think data can help solve?
Yeah, so I think the increase in data has been astronomical. There's a statistic that we use commonly that since 2016, there's been a 900% increase in clinical data. It's the challenge with clinical data is that again, it is in multiple different formats and from multiple different sources, and there's considerable variability that exists that's caused by electronic health record platforms, but also caused by, each of us as providers, have different ways of documenting. There's, a fair amount of jargoning. So in addition to the volume of data, there's tons of variety of data. So as an example, we see with labs, there's a test called a hemoglobin A1C, which is a lab test that actually looks at control of diabetes. there's 150 different ways of representing that we've sourced in one particular pilot across different care experiences for patients. And if you have 150 different ways of sort of representing it, it's really tough to kind of tell a story and to do downstream analytics when there's such variability in the way that's documented. You would think
that's 150 ways, why, to say that someone is diabetic?
No, to document just a test, hemoglobin A1C, for diabetes in a clinical record. There's different codes, there's different display names, and that leads to real challenges in terms of how that data is analyzed downstream. Another example is with COVID-19. You would have thought that would have helped things. A COVID PCR in electronic data can be documented in, again, another 150 different ways. And actually, even to just confound the issue, documenting negative or not detected has about 40 different ways that we've seen it represented. So just the word negative relating to a COVID test has different ways that it's documented. I think some other challenges that people experience is that I don't think that people that are using health data fully understand the complexities and the variabilities. And so that requires a fair amount of education. I think that while standards for electronic health record data transmission have existed and have been central to how users use electronic health record data, again, there is a lot of variability that deviates from standards. And while there's rigidity in how it can be documented in a record, there's nuanced variability within each separate documentation. And I think the other thing that people don't realize about clinical data is that providers document for a whole host of reasons, right? I mean, keep in mind that providers get reimbursed, by the way they document. They also, they also capture, clinical intent in varying degrees based on how they want to communicate with their patients, how they want to protect themselves medically, legally, et cetera. And so that way of documentation that varies and for a whole bunch of different reasons doesn't always capture clinical intent the way clinical intent was intended to be captured in a record. And so I think people that use data downstream and people that use data from other providers need to understand some of the challenges in documentation and some of the variability that exists there. So I'd say that those are the biggest challenges. But I think from these challenges come opportunities. It's really that harmonization of this multi-source, multi-format data to really capture the clinical intent and the real reason for documentation that really is going to be transformative for our healthcare system. It's going to transform it from a sickness-based model of health delivery that's very reactive into something that has the potential to be more proactive, predictive, and certainly personalized for individuals.
That is the goal, yes.
For sure.
So you will be speaking about using NLP to drive medication instruction parsing at the upcoming Healthcare NLP Summit in the first week of April. So without revealing too much, can you share more about this new approach?
Yeah, so I think there's very clear places that NLP can help clinical data. As I mentioned before, there is structure that exists to clinical data, and there's coding systems that allow for some of that structure to be codified. The challenge is that there's a lot of prose and a lot of unstructured data that's actually captured as well. That's really good to provide insights into what the structured data is truly saying. And so I think there's specific areas within clinical data that's captured in electronic health record that NLP can drive value. One is, it can start to provide adjectives to some of the structured data, provide insights into more granularity into how that structured data, is captured. But on the medication side, so I think there's an imminent need. In the United States, 50% of medical errors and 20% of adverse events, at the medication level are really problematic communications at the point of transition of care. So somebody going from a hospital setting to an outpatient setting. Mm-hmm. There's a lot of look-alike and sound-alike medications, and there's an increasing body of medications that are, constantly hitting the market. There's, the cost of medication errors, $40 billion per year to treat people who were victims of medical errors. And, the death toll is, just under 10,000 when it comes to the consequences related from medical errors. And these errors come in multiple different forms and formats. A lot of times it's things like misinterpretation or miscopying from one time to another, failure to really capture changes in things like dose and frequency that may have happened. And then, transcription errors are obviously a part of it. I think the other thing that started to happen with medications is that, in the past, it was pretty standardized. It was a one size fits all. There were very discrete doses and dosing regimens of medications. But as medications have become more complex, and as we're moving more to handle more severe diseases in non-critical settings like hospitals, patients are being asked to deliver their own medications, for example, at home via injection, or at home via, even infusion. And those ways of delivering medications sometimes don't have a very rigid structure in terms of how those medications are actually written. And so the example that I often give is that, you take Tylenol, it's Tylenol, 500 milligrams, it's, take 2 tablets every 4 hours as needed for fever. That's a traditional way that medications were written. You look at things like insulin, which tend to be much more complex. It doesn't have all of those key components, right? It may have double of some key components. It might be, hey, if your sugar is between 0 or 200, don't take any units. But if it's between 200 and 201 and 250, I want you to take 2 units. And if it's between 251 and 300, I want you to take 4 units. And every provider documents that differently in different nuances. I think that to augment the way that this medication decision-making is happening now, natural language processing has a really key value to add to just enhance the granularity of that medication data capture and to get closer to perfection with that. And again, medications are a big issue, right? I mean, we know that, the average elderly complex patient, for example, has 19 to 20 different doses of medications. And this complexity is a real issue. If we don't do transitions of care appropriately, there's a risk of readmissions, and those readmissions have a cost associated with them. We know that patients don't necessarily follow up the way they're supposed to follow up after admission. So just making sure that the data capture and the data transfer at these transitions of care is appropriate. I think that that's where technologies like ours at Diameter Health, augmenting them with natural language processing, can actually help the issue.
So do you really see, you said the average complex patient takes 19 different doses of medications?
Correct. Yeah. So you look at an elderly population, that's very, very common. And again, you may have one med that you take 3 times a day.
Yeah.
But if you have 6 meds like that, right, that's 19 doses. Every one of those doses has to be transacted from a data standpoint to be clearly understandable, not by only patients, but by all others who are involved in that person's care.
Yeah. So when you look at applying NLP in healthcare, what are some of the main challenges that you see in practice?
Yeah, so I think one of the things that as medical providers we have as a challenge is that there's inherent probability in the way care is provided. So if somebody comes into my office and they have a set of symptoms, I'm not saying 100% security that this person has disease X. I'm saying, hey, what are the top 10 diseases and what are those probabilities in my head based on the information that I'm being provided? I think natural language processing, has some probabilistic aspects to it. And I think that while we as clinicians are very comfortable with the probabilities because we're in control of those probabilities, sometimes having that outside probability, that's influencing the way we provide care, isn't always as open and honest, as open to us and transparent to us. And I think that becomes an area of concern. I see solutions like natural language processing as being equivalent to my stethoscope, right? At some point, it is solutions in the tech space that are going to be integral to the way I practice medicine and are only going to augment and make me more effective as a clinician. And I think that ultimately, we worry about technology rendering certain roles obsolete. That's not the way I think about it. I feel that those that don't adopt technology, will be made obsolete by those that do adopt technology. So it's not that machines are going to replace, humans. It's really that people that are comfortable with using technology are going to replace those that are not comfortable are not comfortable using technology. Yep. I think other challenges that exist is that medical documentation tends to be very jargoned. And so while there are standardized approaches to documentations, abbreviations can vary by geography, specialty, and even by providers. And heck, I've documented same clinical conditions in multiple different ways within a patient's chart, depending on whether it's Monday morning at 8 a.m. or Friday at 6 p.m. Whether I've had a bad day and maybe I'm just too busy that day. So all of those things and those nuances are an issue. I think that medical documentation is complex, and one of the challenges that I see, for example, with natural language processing solutions is things like negation, right? Saying that someone has a history of diabetes is different than saying that someone has no history of diabetes or no family history of diabetes or family history of diabetes. And so making sure that the true nuance of not only that one term, but the whole context of the way things are written up is clearly important. And so, I think that the other thing I'll add as a complexity is that, there are disciplines like, for example, mental health, where codification is being done and there is structure to the way notes are written. Medical records don't read from a natural language standpoint as consistently as records in other disciplines. So, for example, legal documents tend to be much more, conformant. Medical documents tend to be all over the place. And if you look at something like mental health, which is really a lot of narrative text to tell a story about how someone's gotten to a state of mental decline, it's disciplines like that I think are adding a layer of complexity onto this as well. But I do think that it's evolved, certainly during my lifetime. It's going to continue to evolve, and it's going to be a really amazing tool that's going to add to how we practice care and how appropriately, how error-free, and how patient-focused that care is being provided.
That's where we want to be. So where do you see us getting in, say, 3 to 4 years from now?
Yeah, so I think that as we kind of talked about earlier, when I go and see a patient, I have a really big internal monologue in my head about all the things that I'm kind of piecing together. And, that internal monologue doesn't necessarily always make it into the clinical notes. And some of that is because of the fact that when you write what goes on in your head on paper, you lose some of that, some of the color and some of the thought that kind of goes into that. And then when you confine it with standards, as is the case of electronic health record, you further confine that.
Yeah.
I think that the future is, really around NLP unlocking some of that unstructured data that's captured in notes that, the provider intended when they were having that internal monologue in their head. And I think even being part of, not just simply capturing context clues that may be documented, but really kind of following provider documentation patterns and figuring out things that may not be documented. Understanding that a provider, when they see someone with chest pain, has a particular algorithm that they may have in their head, and maybe starting to capture some of the nuances from records that, provide insight into that algorithm. I think that, as I explained, natural language process right now can actually be very helpful in providing adjectives to some of the nouns that are existed in structured formats, for example. But I see it really as evolving beyond just simply the adjectives and really true, full clinical intent. I think it will make payer-focused initiatives like, risk and quality much more streamlined. I think it'll make nuances of public health reporting, like we experienced with the COVID pandemic and all the different ways of reporting not only COVID, PCR, but also negative and positive. It's going to make that more streamlined. And I think in the same way that interoperability from a structured standpoint has evolved from technical to really capturing semantics, I think natural language processing is going to follow that same journey. It's going to be less about figuring out what each of those words are and really trying to abstract the meaning from the overall, body of work that's documented in that clinical record.
I have many more questions, mostly about the details of how, what you get and how you get it done, but, we are out of time. So we'd like to thank you very much for joining us today and sharing your knowledge. And everyone, if you want to hear more from Paulo, please join us at the Healthcare NLP Summit on April 4th and 5th of next year. And Paulo will be joined with 30 other expert speakers that will talk about state-of-the-art NLP applications in healthcare and life science. It's a free virtual event, and we'll share the link to register here. And with that, thank you everyone for joining us today. And Paulo, thank you again.
Thank you, David.